This is a lecture for Respiratory Therapy Science 2, Unit 5. Unit 5 is going to cover arterial blood gas draws. It's going to cover indications on when to draw ABGs. It will go over some quality control for the blood gas machines. And at the end, we will also go over and review arterial blood gas interpretation. There will be a video within these slides, so you can find the video on Brightspace. If you just go through the PowerPoints, there'll be a link that you can click on to watch the video. We'll also practice ABGs when we're able to get back into the lab. We can practice with the arm in there, and then we will eventually, hopefully, comp out on arterial blood gases before the end of the semester. All right, so the term ABG stands for arterial blood gases, and that will be used when discussing drawing a sample of blood from a patient's artery for the purposes of determining the arterial pressure of oxygen and carbon dioxide, acid-base status, which is done through the pH, and other related values. So some other things that you'll get on there are base excess, you'll get an SaO2, you'll get a bicarbonate level. So those are some things that will be coming up on the arterial blood gas. When you draw the blood gas, those are the things that will be coming up on the report. So there's generally three broad indications to draw arterial blood gases. One is to check a patient's arterial oxygen status, and that will be done through the PaO2, or the partial pressure of arterial oxygen. And that's the portion that's dissolved in the plasma of the blood. It's what is left after the hemoglobin molecules have been saturated. It's used to check a patient's acid-base status, and that value that we look at for that is our pH. And it's also used to check a patient's ventilation or alveolar ventilation status. And so we can look at a patient's ventilation by looking at their PaCO2, or their partial pressure of arterial carbon dioxide. So we always do ABGs on our ventilated patients, usually about 20 to 30 minutes after intubation and initiation of the ventilator. And then after that, we do it per physician order. So we'll take a look at those blood gases, and then we can go ahead and manipulate the ventilator to better suit the patient based on those blood gases. You know, either if the PaCO2 is high, we would increase their respiratory rate or their tidal volume. If the CO2 is low, we would decrease the respiratory rate or the tidal volume. Then we can look at oxygen status and either increase our FiO2 or increase our PEEP level to help with the oxygenation. Other indications for ABGs, anytime oxygenation or ventilation is in question. So anytime we're questioning whether the patient is oxygenating or ventilating, we'll go ahead and do an ABG. We'll do arterial blood gases in patients that have cardiac failure. So that could either be a congenital defect, so something that they're born with. If we suspect that the patient had an MI or a heart attack, we can draw the arterial blood gas in the emergency room. And then congestive heart failure with or without pulmonary edema. We draw blood gases on our chronic patients. So any patients with COPD generally have had a blood gas draw, and that can include diseases like asthma, emphysema, bronchitis, and bronchiectasis. And then any pneumonia causing hypoxemia. So if the patient comes in with pneumonia and we have them maybe on high levels of oxygen, we can draw an arterial blood gas to get a better, more accurate reading on that PaO2. We can draw blood gases on patients that come in for trauma. That could include things like broken ribs, flail chest. Flail chest is 3 or more broken ribs in a row. It kind of creates an indentation in the chest area. We can draw them for pneumothorax, which is air in the pleural space. We can draw them for a patient with a hemothorax, which is blood in the pleural space. And then anyone who has any upper airway trauma, we would want to draw arterial blood gases to make sure that they're able to ventilate and oxygenate properly. We use them in patients with ventilatory failure, and that can include things like overdose of sedatives or pain relievers, patients that have had any head injury or brain injury or stroke, anyone who comes in with a spinal cord injury. Our diaphragm works off of a nerve that comes from the cervical spine, so any spinal cord injury could affect the diaphragm. And then neuromuscular diseases such as myasthenia gravis or Guillain-Barré syndrome. These two muscular diseases eventually do reach the diaphragm, which makes it very hard for patients to ventilate. Myasthenia gravis generally starts in the head area and works its way down. So maybe it would start with like a droopy eye, and then the muscle weakness would work its way down the body. Guillain-Barré syndrome is the opposite. Generally, they have tingling and numbness starting in their feet and leg area, and it works its way up the body. We would draw blood gases in patients that have foreign body aspirations, laryngeotracheal bronchitis or croup. That's kind of a rare occurrence. Most babies or toddlers with croup generally don't need to be hospitalized with ABG draws, but if it's bad enough, we can draw an arterial blood gas on that. Epiglottitis, and then some miscellaneous ones, smoke inhalation and carbon monoxide poisoning. Most blood gas machines now do have co-oximeters on them, so if we run or draw a blood gas and run it through the machine, we can get a carbon monoxide reading as well. Patients that have had a near drowning incident, because a lot of times they did have asphyxia for a while, or so they're without oxygen for a little bit. And then infant respiratory distress syndrome, another name for that is hyaline membrane disease. And so this is what happens when babies are born too prematurely. They do not have enough surfactant, so they cannot keep their alveoli open. So with this disease, we would draw arterial blood gases to make sure that they are oxygenating and ventilating properly. We would draw them in our adult patients that have adult respiratory distress syndrome. If the patient does not have an indwelling arterial line. So we do use art lines when drawing a large number of ABGs, so you don't have to repeatedly stick the patient. An arterial line goes into the patient's artery, and then it stays there, and then you can just draw blood right off of that line. You'll probably see this done quite a bit at the University of Iowa, and you will get to draw arterial blood gases through an art line there as well. If you're trying to do a shunt calculation, you need to draw an arterial blood gas because you need the P little AO2 in order to do that. And then cardiopulmonary resuscitation, usually either during the CPR resuscitation, they'll ask for an ABG, or after you get a pulse, they'll ask for an ABG. Many times that is done in CPR, it's done in the femoral artery, which the physician would draw off of the femoral artery in most institutions. It's just going to depend on the hospital's protocol. Some contraindications, limb paralysis, you wouldn't want to do it in, if they had, paralysis of their right arm, you would not want to draw in the right arm. If they've had multiple punctures, so sometimes you'll go up to these patients and they've had numerous punctures, and so they have a lot of bruising and hematomas. And then patients with circulatory impairment, and we'll kind of talk about what we do to check for that before we draw arterial blood gases. Steps to obtain an arterial blood gas sample. So we'll go through these steps, and then, like I said, there is a video that you can watch to watch the actual procedure being done, and then we will practice in the lab. So some steps to obtain an arterial blood gas sample. We want to get the appropriate blood gas kit. Most of them are already prepackaged, so you don't have to package them. And they will contain a variety of short beveled needles, usually 5/8 to 1.5 inches, and 20 to 25 gauge needles, 22 to 24 gauge needles. 1 inch long needles are used for a radial stick, dorsalis pedis puncture, which is on the top of the foot, and a brachial stick, and a 20 to 22 gauge for a femoral puncture, and that needle would be 1.5 inches long. For needle sizes, the larger the number, the smaller the needle. So a 24 gauge needle would be smaller than a 20 gauge needle. And then for infants and children, we generally will use a 25 gauge needle, or sometimes they'll just use a small little butterfly needle to draw the ABG. ABG syringes are 3 to 5 milliliters, and many kits will have the syringe prepared with heparin, which is an anticoagulant. So right inside the arterial blood gas needle, there'll be heparin in there already. Back in the olden days, we used to have to draw up the heparin and coat the inside of the needle before we drew the ABG. Now they come pre-prepared with the heparin in them. We need some sort of recapping device, and there's some pictures there that show different recapping devices. Just for example, like the middle one, the orange one, you would just push the needle into that until you heard it click, and then you would twist off the needle part of the syringe. And then the last picture there on the right, it just shows kind of a recapping device that has that blue little tip hanging down, and you would just push that against the table or something to cover the needle. And then again, you can twist the needle off and throw that into the sharps container. Ice water in a cup to prevent metabolism, and we'll talk more about that in a little bit. Most patients do not do this anymore, and you really don't have to put it on ice if you're going to run the arterial blood gas right away. So again, hospital protocol, but most places do not do the ice. You need some alcohol swabs or iodine swabs to clean the puncture site, sterile 4x4 to aid in clotting. You'll need clean gloves, face shield, eyeglasses, or goggles. So the first step when you open the arterial blood gas is using sterile technique, screw the selected needle onto the syringe. Most of the syringes are Lurlock syringes, so you'll need to place the needle on the syringe. You want to make sure that you have a valid physician order to draw the arterial blood gas, or if it's part of the hospital's protocol to draw blood gas, for example, after somebody has been intubated and put on mechanical ventilation, maybe that hospital has a protocol that everyone gets an arterial blood gas after 30 minutes. Check the patient's chart for any pertinent information. You want to see what kind of supplemental oxygen that they're supposed to be on. So if you're supposed to draw the arterial blood gas on 5 liters per minute, make sure that the patient is actually on 5 liters per minute. Look at the patient's history, the patient's temperature, because that can cause a right or left shift of their curve. Their hemoglobin, make sure that they're not anemic or polycythemic. Check the chart to look at bleeding disorders such as hemophilia, patient's clotting time, because a hematoma will result if extra time is not spent holding the puncture site. Normal activated partial thromboplastin time is 38 to 42 seconds, and prothrombin time is 10 to 14 seconds. If the patient is receiving anticoagulant therapy such as heparin, aspirin, or Coumadin, the prothrombin time will significantly increase, so be prepared to hold the site for longer than normal. So if you go in there and see that that patient is receiving heparin or Coumadin or even on like an aspirin per day, and you draw that arterial blood gas, you're going to need extra time to hold pressure to stop the bleeding for that patient. All right, so this is the end of the first recording. We will go ahead and continue the second recording in a little bit. Thank you.